Awesome. Well, hello class. My name is Devin, and my fellow presenters are McKenna, Spencer, and Hannah, and we're going to be talking about adult and adolescent suicide assessments. So the first assessment we'll go over today is the Columbia Suicide Severity Scale, or as it's commonly referred to as in its abbreviated form, the C-SSRS. So when it was being created at Columbia University, Dr. Kelly Posner and her team of scientists and behavioral health experts set out to create an assessment that could solve the biggest issue they ran into in suicide assessment, the lack of a common language surrounding the topic, which leads to difficulty in understanding the true severity of a client's situation. So since its creation, the CSSRS, this great tool has become the standard for suicide assessment and severity. It has more than 600 peer-reviewed studies that have been published demonstrating its use with different populations and its validity as a whole. So at its core, the CSSRS is a simple set of 6 questions that can be shortened to even 2 that helps the clinician gauge the severity of the client's immediate suicide risk based on the client's answers to the assessment questions. So it's simple and provides a fairly quick assessment to the clinician, which lends to its usefulness as a general tool for practitioners. So, however, we will continue to expand upon in this. My apologies. Later in the presentation, we'll talk about some other means we can use to assess, because there can be different and even more approachable methods for different populations. But what we can say is the CSSRS is a great general tool and technical tool. It's standard and can be used with just about any population or person.
It's helpful to see the assessment process in action. So we have provided a few links here that will help that you can reference on how to apply the CSSRS assessment. And here we have a video from the United States Air Force Chaplains Peer-to-Peer CSSRS screening demonstration. The Oregon Health Authority provides a webinar for training in the application of the C-SSRS. On top of training on how to use the assessment tool, the slide deck highlights issues and concerns specific to the state of Oregon. It is a great resource to refer to for more information about how to provide care to clients and patients within the state of Oregon, because it provides information about the initiatives, programs, and resources available in the state. When we are using this assessment tool with clients or patients, it's important to have a working knowledge of our language about and around suicide. We have included a link here that provides information about the vocabulary associated with suicide, as well as recommendations and tips about the terminology we use when assessing for suicide. Here are the resource Words Matter Suicide Language Guide. A quote directly from this document states, "Whether we are engaging in a dialogue, talking to someone with lived experience, or writing about the issue in a professional setting, being mindful of our language is not just about being politically correct, it's about saving lives. As our knowledge and understanding of suicide evolves, the way we talk about it must evolve as well. To help you be more conscious of your own language decision, this guide will show you how to avoid reinforcing the stigma that prevents people from seeking help when they need it most."
All right, and for teens, we chose a brief suicide safety assessment by the National Institute of Mental Health. It is part of their Ask Screening Questions ASQ toolkit, and the NIMH developed the BSSA originally for pediatric emergency departments among, I believe, 3 different hospitals. And it's now used in a variety of settings after extensive testing. And the BSSA is also used to screen individuals with autism, and it has been translated into 16 languages. The BSSA is administered after a risk for suicidal ideation has been made clear. And we provided multiple links to see the suicide screening tool along with the worksheets.
So the BSSA has 5 basic steps. The first step involves praising the patient for discussing their thoughts. Especially with younger patients, this may be their first experience speaking about suicidal ideation or their mental health at all. Praising their honesty and vulnerability will contribute to the therapeutic alliance and increase the likelihood of continued contribution to a difficult conversation. The second step would be assessing the patient for a variety of factors. First and foremost is the frequency of suicidal thoughts, followed by whether or not they have a suicide plan, identifying a potential past suicidal behavior, exploring more their symptoms, and identifying their social support and stressors. After you assess the patient for those variety of symptoms, you interview the patient and the guardian together. Ask the guardian, especially if the patient's under 18, share the results of the assessment of the patient with the guardian and determine if they were aware of the reported information. The fourth step involves making a safety plan with the patient, identify who the patient can get in contact with if they've had distressing suicidal ideation, discuss a wide variety of coping skills to manage stress, and have restrictions in the home for potential means of suicide. The fifth and final stage is determining disposition. So this would involve determining whether or not the patient needs an emergency psychiatric evaluation, if further risk evaluation is necessary, or if the patient will benefit from a non-urgent mental health follow-up. You're muted, McKenna.
Thank you. We've included some shorter and longer BSSA training videos on how to complete that. And we also have included a video of safety plan making for your review. And lastly, if you're having trouble with any of the hyperlinks, have no fear. We have full web addresses here just in case you're experiencing any technical difficulties. Again, thank you so much for listening to our presentation, and we hoped this has been helpful for you.